Thank you very much, Krish, for your kind words. And I'm delighted that we have an audience here that represents sickle cell disease clinicians, scientists, policymakers, patients and families, advocates, and industry. So we have a broad selection of all the multiple stakeholders that need to really tackle the problem of sickle cell disease. I will start with this cartogram that was produced by Fred Peel and his colleagues in Oxford, that if you look at this, the world's map of sickle cell disease cases diagnosed, and you drew a cartogram both through systematic screening and through pilot programs, that the world map drawn to scale will look like this. Nigeria, Democratic Republic of Congo, and India combined will represent 50% of the population of sickle cell disease in the world. That means that whatever we do, unless these three countries are involved, we are only scratching the surface of sickle cell disease. But there's another cartogram that I also like. And this is if you drew the same cartogram according to resources for treatment and for research, you'll see that it's the exact opposite. So the resources are in Europe and America and very limited in Africa, India, the places of the world where the disease is most prevalent. So the challenge we have is tackling a problem that is most prevalent in areas of the world with low resources. That means that we have to find quick solutions that are innovative. What are the causes of mortality in sub-Saharan Africa in patients with sickle cell disease? Malaria is an issue, severe anemia due to malaria and Spanish sequestration is a cause of mortality. Infections are common causes of mortality, and acute chest syndrome and multiple organ failure. This list is not comprehensive, but at least it tells us the main causes of mortality. The effective interventions that we had in the first day by Professor Henry Frimpong have been actually interventions that are simple. Early diagnosis, penicillin prophylaxis, pneumococcal vaccination, parental education, and access to comprehensive care. And lately, with disease-modifying therapies, have been responsible for the fact that over 95% of children born in Europe or United States or Canada will expect to become adults. It is not the same in Africa, where 50 to 80% of children born with sickle cell disease would die before the age of 5 years. And we saw this data yesterday as well. The WHO has reported that 9 to 16% of under 5 mortality in certain parts of Africa will have some attribution to sickle cell disease. And the reasons are very simple. Health systems are very weak, both in utilization and quality. There's poor implementation of well-known sickle cell-directed policies. And what is even more staggering is that there's a slow epidemiologic shift happening, that children are more likely to survive more as we have pneumococcal vaccination becoming available in these parts of Africa. So with time, the burden of this disease will increase. But simple programs can prevent mortality. And I like this because this is comparing under 5 survival rates in patients with sickle cell disease in various parts of the world. And what I want you to note is that is United States and England, that is Jamaica. Thanks to the work of Professor Sargent and the group, you can see how survival rates can be achieved in even low-income countries. But look at Republic of Benin, and Sharif Rahimi is seated in the audience. A good program in Benin with early diagnosis, good supervision, education of parents, treatment of infections, is achieving the same survival rates as you see in richer countries, telling us that this is effective. Newborn screening is not only life-saving. We now have evidence that it is cost-effective. And I think policymakers need to hear this. This was work done in Angola by the group from Texas Children's Hospital and also Cincinnati Children. And this was a publication of a newborn screening program they did in Angola. And with the help of Scott Gross and others, they were able to compute the gain by preventing early mortality and preventing morbidity, if you consider the GDP of Angola and the healthy life years gained, that you could actually save a lot of costs. The gain in healthy life years was about 500, but the cost against this gain was in the 1,500 range to 3,000. So this is generating some useful data to suggest that not only is it life-saving, that it is also cost-effective to do newborn screening, detect them very early, and prevent the morbidity and mortality that is associated. But one of the themes of this conference is breaking the barriers. And what are the barriers? The cost of testing, anywhere $5 or more, is prohibited. Not many countries are committed to being able to screen every child born at that level of cost. And when you have detected patients, it is tough to identify even screen-positive patients. Professor Henifrimfon has achieved up to about 70% retrieval rates, and that's about the best that we've been able to achieve in Africa. Most areas in pilot programs have been able to achieve 50%. So it's a challenge. Case management of patients is a problem because of access. Primary care facilities are not well integrated, and the management of sickle cell disease is not integrated into these primary care centers. Sickle cell centers are few and far between. Only few dedicated sickle cell centers can be found in these countries. And lastly, information technology that gives accurate database to tell you the numbers of patients and where they live, which part of the country they live, are not available, which really makes it very difficult for healthcare workers to communicate with each other. So what do we need to do in these low-income settings to overcome these barriers? Newborn screening is feasible. It's been done, and I don't think that we need any more evidence. Jamaica has shown it, Ghana has shown it, Benin and DRC have demonstrated pilot programs. But in most of these countries, except Jamaica that has really expanded recently, most of these countries, these programs are still limited. They've never become universal. Immunization is important. We heard that the work done in Kilifi showed that pneumococcus is still a killer, and that if you can prevent pneumococcal infections, you will save lives. Malaria is a cause of morbidity and mortality in sickle cell. Whereas we know that the sickle gene protects against malaria, we do know that when sickle cell patients develop malaria, they are more likely to die. And so we need anti-malaria strategies to prevent this complication and death. And then lastly, we need to integrate care of these patients into primary care programs and systems within these low-income countries. So here are some solutions that I'm thinking about, and I think we ought to sort of think about how we can find solutions in low-income countries. So in high-income countries, they all have universal newborn screening programs, congenital hypothyroidism, metabolic disorders, phenylketonuria. These systems are already in place. So doing universal newborn screening for sickle cell disease is a problem of adding an extra menu to the test. Easier to establish. Early intervention, we've already shown. But what do you do in low-income countries where there's no universal newborn screening program for any disease at all? So with that, I think point-of-care diagnosis offers some opportunities for solutions. First of all, the point-of-care diagnostic tool, if it is cheaper, lends itself for use. It doesn't require a lot of training, and the challenge of actually retrieving the screen-positive child is much less. And I think that immunization visits, which is very well established, we heard about Coca-Cola the first day, that Coca-Cola is well-established network of commercialization and distribution. Another intervention in health that is well-established and has stood the test of time is immunization. So wherever children are born, in most countries, they have access to immunization. And I think we should think of how we integrate sickle cell care in some way to these successful systems that have been established. We've already shown that these early interventions can be done. They are being done in Benin, they are being done in Ghana, in Kumasi, They've been done in Jamaica for many years. And Gavi initiatives are being successful in providing primary pneumococcal vaccinations. So we have opportunities there to be able to integrate all these services within primary health care. The point of care diagnosis, there's a whole symposium on the last day, and I will encourage all of you to be there, because we have most of the leading developers of point of care diagnosis here in this conference. And in that symposium, they're going to discuss some of the developments that are being made. We need to reduce cost of testing. Second, the level of training required to use these devices has to be very low, so that no matter where they are done, it will be possible to interpret the results. These diagnosis tests have to be accurate, because if they are inaccurate, they are not sensitive or specific enough, then that we are going to have barriers in being able to identify these patients. Point of care diagnosis removes the barriers of trying to now trace the screen-positive child and intervene. It is easier to integrate into primary healthcare systems, and if it's low cost, it is better able to be practiced in low-income settings. So I'll just show you pictures of some of those and come to the symposium. This is Sickle scan, probably the most well-advanced lateral flow immunoassay. There's another one called Hemotype SC, which is also based on the lateral flow immunoassay, where people can be trained just to interpret bands or the absence of bands to determine the presence of hemoglobin. There's the microfluidic electrophoretic system called HemChip that allows one to be able to diagnose these patients within 10 or so minutes by using microchip electrophoresis. And this can be linked to a mobile device that allows interpretation of the results. So, in high-income countries, chronic blood transfusion is available. Exchange blood transfusion can be done. Hydroxyurea therapy is available, it's accessible, it's not expensive if you take it into consideration high-income countries. Bone marrow transplantation is now becoming increasingly available. But most low-resource countries have challenges doing chronic blood transfusion and ion chelation. It is not feasible in most low-income countries, and therefore that doesn't offer us any tangible population-based solutions. So what do? I think hydroxyurea therapy needs to be explored. We're going to have another symposium in the memory of Professor Bima Carr on how hydroxyurea can be used more extensively. And I think one area in which hydroxyurea can be of benefit is in stroke prevention, which is the most perplexing and the most devastating complication of sickle cell disease. TCD testing is not easily available, and in fact, I think that even when they are not available, by using hydroxyurea more effectively, we might be able to prevent stroke in many patients. In an earlier session today, we heard about nutritional support, that micronutrient deficiency and nutritional deficiency is a big problem, particularly in areas that have high incidence of sickle cell disease. And when they come and they are undernourished and they are iron deficient, nutritional support is indeed very important. Disease-modifying therapy. Chronic blood transfusion is not feasible because it is costly and many countries still have inadequate blood supply. Hydroxyurea is the only feasible disease-modifying therapy that can be implemented to scale, and I think we should take advantage of it. It is affordable, relatively, easy to administer, and efficacious. Comprehensive care programs that link primary and secondary programs need to be established so that there can be grades of care where more serious cases are treated in specialized sickle centers, but less severe complications can be managed at lower levels of care. The evidence for hydroxyurea is very strong, and I don't need to go about it again, but this is a map of the WHO showing availability of blood products in the world. The red shows poor availability, the green shows high availability. And as you can see, in areas of the world where sickle cell disease is very prevalent, access to blood transfusion is a barrier. And that is why chronic blood transfusion is a challenge in these parts of the world. But we need to prevent stroke, whether first stroke or recurrent stroke. If we don't prevent stroke, those who suffer stroke are really going to be a burden not only to themselves and to their family, but also costly to manage. We now have evidence that actually hydroxyurea may be able to replace chronic blood transfusion to prevent primary stroke. And this was the work done in the TWIC trial that was published in the Lancet. But the incidence of recurrent stroke also can be reduced with hydroxyurea. This data shows that hydroxyurea, although not as good as regular transfusion, a meta-analysis of all trials that have been done using hydroxyurea for secondary stroke prevention shows that regular transfusion will reduce stroke from 29 per 100 patient years to 1.9. But although hydroxyurea is not as good as regular transfusion, it is far better than no therapy. And that's why at least hydroxyurea is available and should be able to prevent stroke, recurrent stroke, in patients who have sickle cell disease. So I will submit that no child who's had a stroke already should be denied access to hydroxyurea. So what are the feasible solutions? I think early diagnosis at the point of care is now technologically possible. But the challenge is to get the cost at the $1 range. And that's what we all have to do together. If we can get one of these diagnostic tests less than $1 a day and be able to integrate into immunization programs, I think we'll overcome the barriers of not being able to detect them early. Simple early intervention should be linked to primary care, and these are affordable and should be scalable. Hydroxyurea should be used, and access to it should be improved as early as we can. It is efficacious, it is feasible, and now international multi-agency partnership needs to be established. Many years ago, HIV broke, and AIDS became an established phenomenon. The cost of antiretroviral therapy was prohibitive, and nobody ever dreamt that today, whether you live in rural Africa or India or Nepal, if you have HIV, you will have access to antiretroviral drugs to treat your HIV. I think we need that same model, develop that model, which requires multi-agency partnership, industry, global funders, clinicians, researchers, governments, WHO, all need to come together to make disease-modifying therapies accessible to every patient with sickle cell disease. Let's raise public awareness and combat the myths and the stigma associated with this disease. We need public education and awareness so that health professionals and providers will have knowledge to treat these patients. Patients and families should be empowered to know what they need to get so that they can put pressure on policymakers to make these interventions available. Policymakers should be part of the discussion, and I'm happy that there are representatives of policymaking agencies, the ministries of health and the governments here, because without policymakers, we can't make any headway. And advocacy is so important. In my work as the Director of Global Sickle Cell Disease Network, one of the things that I've observed that virtually in every country, advocacy for sickle cell disease is fragmented. It has so many partners that do not work together. I think we need to overcome those barriers because advocacy has to be strategic and effective. It has to be strong and collaborative. It has to involve patients and families. The advocacy groups and NGOs need to work hand in hand with healthcare professionals and with government and policymakers so that the advocacy will be coherent, will be supported by evidence, will be one united voice that actually gets work done. And with that, I will say thank you for your attention.